Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning into my latest video. So I have a very interesting case I performed today actually, and it's of a client who travelled all the way from Wales to attend my clinic. So Wales, just to put it into perspective, it's about a 3.5 hour journey each way, so 7 hours in total. And they'll probably be watching this on YouTube because that's how they heard about me and found me. So they are a subscriber on YouTube. And they attended with, their symptoms were very itchy and irritable right ear in particular. They also had some symptoms in the left ear, some tinnitus, which did resolve itself. Now, as you can see, the ear canal, there's no earwax, it's completely dead skin, dead keratin. And they reported a similar problem around 20 years ago where they were referred eventually to see an ENT specialist who, from what they described, they actually had a blockage at the time, the ear was blocked. And the ENT doctor removed the blockage and also dead skin, and they've not had any problems since until recently. Now, they have got some eczema, psoriasis on their hands as well occasionally. So, but with regards to the ear, they feel it just flared up, and they were hoping that if I could remove this dead skin, that not only would their symptoms would be alleviated, but this condition won't return. So. Now, any problem with the outer ear canal, such as this, we label it under the umbrella otitis externa. So otitis externa is an umbrella term for an inflammation or infection of some sort, or some psoriasis or eczema, as sometimes it's called, of the outer ear canal and eardrum. So for many people, having this dead skin may not always be problematic. They may not feel it, but some people, obviously their ears are much more sensitive, and for this patient they could really feel this, and it was a great relief for them at the end. But these procedures are very tricky because we've just got to be so gentle and delicate. We don't want to, although I want to peel this outer dead skin layer for her, I don't want to then cut into the bony part of the ear canal and expose that to the elements, and which can then lead to a more severe ear infection. So it's a fine balance to strike, and we don't, as you know, I'm an audiologist. We don't prescribe any local anaesthetics. All this was done whilst the patient was awake, without any anaesthesia or numbing agent whatsoever. So I'm just using microsuction, of course, to do this. So we're using it in two ways. Not only are we using it to peel this dead skin, I'm also using the edge of it very gently to kind of, not scrape because that's the wrong word, but to elevate this dead skin off the canal wall. And the problem with the skin, it's very strongly adhered. So skin can, obviously the skin that lines the ear canal, as it's attached to the ear canal. So just to give you some biology and physiology about the skin in the ear whilst you're watching this. So the outer third, so the cartilaginous portion, you have a thick layer of skin, around 1 millimeters in thickness, and that's where you get the hair follicles as well. The hair follicles have glands attached to the root, ceremonous glands, which secrete an oily sweat, similar to the sweat under your armpits, and sebaceous glands, which secrete an oily lipid substance, a bit like the oily substance you get on your scalp, from the hair from your scalp. These hair follicles are only located on the outer third, the cartilaginous, which is also semi-malleable, flexible, and semi-sensitive. The inner 2/3 of the ear canal, the skin is a lot more delicate, and it's adhered directly onto the bony part of the ear canal. And if you make contact with the bony part of the ear canal, the patient will feel it and they won't like it, and they'll tell you they won't like it because it'll be very uncomfortable. So the skin that lines the inner 2/3, it's 0.1 or even less than that in thickness, and we call it stratified, squamous, keratinous, epithelial skin. So the word stratified means layers, and in total there's 5 layers, I believe, of this epithelial skin that lines the inner 2/3 of the ear canal. Squamous refers to the shape of the skin cells. So squamous is more like a pancake shape as opposed to a cuboid shape. Keratin is a protein that's secreted in the outermost layer of the epithelial skin. So when we've got 5 layers, the innermost layer of the epithelial skin has got all the blood supply. And as those skin cells undergo mitosis, so cell duplication and replication, the original skin cell is pushed outwards or to the surface by their daughter cell, we call it. And as this keratinous skin is pushed further and further away to the outermost layer of the ear canal, it receives less blood flow, and the cell itself, obviously all cells have intracellular fluid, and when this skin cell is pushed to the outermost layer of the ear canal, the skin cell is less able to retain this intracellular fluid, so it dries. And as it dries, obviously the skin layer is dying itself because there's less fluid in there to conduct all the cell functions that's necessary in all of our cells. And at that stage, the skin cell itself starts producing keratin. So keratin is the same protein that we find in our nails and our hair. And this keratinous layer has actually got a function. It's hydrophobic, so it helps repel water out of the ear that may enter, which we don't want. We don't want water in the ear, it's bad for us. And also, the keratin itself can reflect UV rays or radiation rays, so from the sunlight, for example. So it's very beneficial in that respect. But typically, in most people at least, as the skin of the ear canal, so we're talking about the whole ear canal, and also the outermost layer of the eardrum, so the outermost layer of the eardrum is actually made up of the same skin that lines the inner 2/3. So the eardrum has got 3 membranes. The outermost layer of the membrane, which is the lateral layer, which is what we can see, is the same skin that lines the inner 2/3, so the stratified, squamous, keratinous epithelial skin. The middle layer of the eardrum, the middle membrane, is more of a fibrous connective tissue, which gives it its structure, its rigidity. And the inner layer of the eardrum is, we call it the mucosa. So it's the same layer of skin that lines the middle ear. So the mucosa layer is always a bit more, the mucosa is like the same skin that's in your nostril, so it's a bit more moist, damp. It produces mucus, hence the term mucosa. So as the skin dies from the eardrum, the ear has evolved over millennia so to naturally transport this dead skin out of the ear. If it didn't, so imagine your ears just said the skin dies in the ear, which it will for everyone, and it just falls and drops into the ear canal, everyone's ears will be blocked full of dead skin. The skin will get infected, patients can't hear, and you'll have constant ear infections. So the ear has evolved. So as the skin dies and sheds, it moves sideways, laterally, like a conveyor belt out of the ear. And for the majority of people, your ears have that ability, and as it migrates, any wax sitting on the entrance, on the surface of the skin, is also transported out of the ear. So the skin, it's very important. However, in some people, this skin stops migrating. Patients who undergo radiotherapy treatment around their ears, it's known that the skin loses its ability to shed and migrate laterally, so they get a skin build-up. But it's just some other people sometimes there's no reason. I found, anecdotally at least, and I can't say there's any clinical evidence, I'm going to have a look and research it further, but people, menopause itself can cause dry skin build-up in the ear, so I don't know if there's a link. Anecdotally at least, I feel that there is. So, and when the skin doesn't come out, now unfortunately this patient doesn't really have wax, so they don't have an excess build-up of wax because the skin's not migrating. They just have this unfortunate condition where the skin migrates. It doesn't migrate, it sheds, it dies, and it just stays in its position, and it builds up. And this skin, it's very thick, so it's very difficult, and we're trying to peel it, and it's like, the best way to describe it is some really strong sellotape on an envelope, and you want to peel this tape off the envelope but without tearing the envelope, and it's similar to what we're doing here. Now, whenever patients have got these skin conditions, I try to perform a dry skin peel because they've obviously got some sensitivity already, And by introducing drops of any form, really, sometimes it can trigger the sensitivity and they can get a reaction to it. So wherever possible, at least, I'm trying to just do this as a dry procedure. And you can see how I'm using the suction probe. So sorry, wasn't really talking too much about the procedure. It was obviously self-explanatory. I'm just peeling skin. But here, the technique, I'm just using it in two ways. I'm using it as a sucker, so we can suction the skin off the canal wall, but I'm also using the edge of the Zollner suction probe, almost like a scalpel almost, and just gently scraping this off. So if you imagine your wallpaper scraper and similar, obviously we've got to be really, really gentle with someone's ear here. And this outer layer of skin, because it's a thicker layer. So remember what I mentioned before, the outer layer of skin on the outer third, it's a thicker layer, so it's about 1 centimetre in thickness, whereas the inner 2/3, the skin layer is a lot thinner, and this is really, really thick. It's almost, I was saying to the patient, it almost feels like an elephant skin. It's got that consistency. And to make the procedure a bit more complex, the patient's ear was very narrow and twisty. The patient was brilliant, very still, kept asking throughout if it's uncomfortable, especially during this part of the procedure, because I'm applying a lot of pressure, trying to kind of just lift it. I'm looking for a purchase. But eventually I explained to the patient that I'm going to have to use some drops because the skin's just too tightly adhered, so just instill some sodium bicarbonate drops, because it's always a bit better for skin, I feel. And it really has helped. So laterally I'm able to get a bit more purchase. And just at the end of the procedure, it's probably worthwhile just rewinding it to the beginning, just to remember what the ear looked like, and then you can have a comparison to what it looked like at the end. It's literally a brand new layer of skin that you'll see once we're done. So again, I'm just using the Zollner suction probe, both almost like a scalpel to kind of almost like the edge of a Jobson horn maybe, or Cawthorne hook, just to elevate this off, and at the same time I'm suctioning, so it has a double impact. So this is more or less on the bony part now, so we'd be really gentle. So the patient's probably still on her way home. She might have actually got home by now. No, actually, she still probably should be on the journey. So I did say to her I'll forward the video. So and she's given her full permission for me to upload it on YouTube. So it'll be a nice surprise for her. She was very grateful and asked if she can come again in future. And I said yes, of course you can. So just attach the fine end gauge here, just trying to get this. You can see that where we're working now, this is a narrowing of the ear canal, and most people have it. It's called the isthmus, so it's about 0.5 centimetre away from the eardrum, and then you get a narrowing of the bony part, and on the anterior canal wall on the right hand side, you can see it slightly protrudes, and then it widens again, so it creates a recess, and we call the recess to the right, so behind this bony part of the ear canal where there's a little hidden cave, so to speak, we call that the anterior, so the front of the ear canal recess, so anterior recess. And a bit later on you'll see I've had to bend the tip of the suction probe to get access into the anterior recess, because it's very, very twisty ear canal. Now this piece of skin, it extends all the way to the base inferiorly, so the base of the eardrum in a region called the annulus, and the annulus is quite a strong connective tissue region of the eardrum, and it's very hard to detach the skin. So I will go back to that. Again, just using the fine end gauge, just almost to just lift. Again, I don't know which other word to use apart from scrape, but we're scraping in a very gentle way. If we weren't gentle, the patient would have really found that uncomfortable because we were on the bony part there. But no, they were really comfortable throughout. Again, just using the fine end gauge. Just wriggling this in circles. But again, there's not much space to work with. So when we want to detach skin or wax, we give it a little wriggle. But you need space to wriggle. And we're really short of space here. So I'm just trying to, again, I'm on the anterior canal wall very medially. This is the bony part. I'm just trying to lift this skin upwards to see if it peels upwards, because it's not really peeling when I'm using the other motion from. So before I was with the fine end gauge, I was bringing the sucker laterally medially, so from outwards inwards, but it was limited in its efficiency, so I'm just trying to, that stage before, using the suction probe to see if I can peel it upwards, see if that makes a difference. So I've just put some more drops in. And so you can see when you put the drops in, the skin kind of, it drops because of the weight of the drops. Because it's wet, it just drops back onto the canal wall. And we're just lifting it back up. Again, I wanted to avoid using the drops if possible, but it's sometimes just not possible. We just got to use it. Now, these are not procedures we perform every day. It's not procedures I would recommend for everyone. And some people wouldn't need it. So many people with this sclerotic skin condition, they just have a spray of some sort, a steroid spray maybe, or acetic acid spray. Now, the patient has previously been prescribed some steroid spray. They had some adverse reactions, and they're not very keen on to spray for that reason. They did go back to the doctor about the condition, didn't really get very far, and hence why they decided to obviously do their research and visit me today. So they've been living with this for a while. As you can see, it's almost a fresh layer of skin, but we're not going to finish there. Patients travel a long way, and again, we want to do the best job we can. Now, appointment slots are 30 minutes. We did go a bit over, but within those 30 minutes, we'll do as much as we can, safely as possible. Now, again, if a patient came in and they just got waxed and we have some residual skin like this, I would completely leave it. I wouldn't try and get this. But for this patient, they could feel this. This is the difference. I've got a couple of clients that when you first visualise the ear canal, you think, okay, it's not going to shouldn't really cause them problems, but it does. So I've got a few clients like that, and I'm more than happy to try and remove the skin. So this is a blind spot of the ear. So when we enter the ear canal, just to where the right is, on the left-hand side, where this first bend curves, it's a bit of a blind spot, and I'm just going into this blind spot. And this is why an endoscope is so great. And the patient could actually still feel this. They could, once I cleared everything else, they felt the ears to be still itchy near the entrance. So I managed to get access into that region. Now and again, the patient can feel this. It says they can feel something a bit deep. At this stage, they were really, really happy. They could feel that the ear was far less itchy, but they felt something near the eardrum, and they pointed it out. And I said, yes, there is a bit of skin left there. So there's a bit of skin here left on the anterior recess. We just peeled that off, and I've just bent the tip of the fine end. Now it's this final remaining piece of skin, and this is really tedious. It just did not want to come out, and we're so close to the eardrum. So again, I'm trying to pull and tug and manipulate this last piece of skin, but we're close to the eardrum. It was really, really tricky, and the ear was narrow, but patient was so still, which really, really helped. I think we are going to put some more drops in a moment just to loosen this last bit, but spoiler alert, I did manage to get it. But I was going to give up. I did say to the patient, I just don't think this is going to come out. So I got a bit there, but again, I still could feel this last bit. I'm a big believer of less is more. If you've been watching my videos, I kind of do say a bit of wax here, a bit of skin there, we leave it. But in this case, it's the opposite. We're just trying to get as much out as possible for the reasons obviously I've explained. You can just see how bendy and twisty this area is. So you have to go into the left, and you get the bend around the right. It's like a chicane almost. Yeah, just so it's hidden away in the anterior recess. I'm just going to get a suction grip, which is really difficult. I think I've just put a bit more drops in. Yeah, you can see some of the drops on the eardrum. So I'm going to go in, suction the drops out first. You can see how that, I don't know, it's like a fluid level meter there. The fluid is the drops is all the way up to the eardrum, and as I put the sucker in, that fluid level just came down. Okay, right on the eardrum, past the anterior recess, so still got a good enough view. Now, if the patient couldn't feel this, I would have left it. I would have loved to have left it because it was really, really tricky. But she did mention still, even at this stage, even after putting the drops, I can still feel this. So we persevered. My hand was really aching afterwards. Yeah, just be really careful not to touch the anterior canal wall. You can see it as when I'm trying to wriggle, we come close to it, but I'm always away from it. If I do touch it, I'm just kissing the surface. I just come out to rest my hand, because your hand does tie when you're that deep in the ear with a fine end and you're wriggling. So just going back in. It's just an amazing view with the endoscope that we get. This is tense, guys. I can sense the tenseness whilst you're watching. It was quite a tense part of the procedure as well, I must admit. So I thought, oh dear, I've made it worse. It's just getting longer, the tail, and then it can flap against the eardrum. I thought, oh dear, what have I done? But I wasn't going to give up. There we are. Managed to do it. So, I hope you enjoyed that video, guys. Bit of a different type, and I hope the patients watching